Hi everyone, welcome back to your channel I Love Pharmacology. In this session, let us understand a very important topic under pharmacology, that is adrenergic drugs or adrenergic receptor agonists. Myself Dr. Padmanabha TS, your pharmacology faculty. So in this session, you're going to understand what do you understand by adrenergic receptor agonist, how they are going to function, what are all the receptor which are responsible for mediating this adrenergic receptor agonist or the adrenergic drugs, and also let us understand how these catecholamines are synthesized and what are all the pharmacological actions and the classification of adrenergic receptor agonist and also the indications and side effects. So without wasting much time, let us understand what do you understand by adrenergic drugs. So adrenergic drugs are the one which will going to mimic the action of adrenaline. So adrenaline is one of the catecholamine that is synthesized endogenously along with the norepinephrine and dopamine. So those drug which as the adrenergic mimicking action, they are called as adrenergic agonist. So the agents which are activating the adrenergic receptor, they are also called as sympathomimetic agent, because all these drugs under the adrenergic group of drugs, they have properties similar to that of the sympathetic nervous system. So the agents which are activating the adrenergic receptor, that is the alpha and the beta receptor, they are called as sympathomimetic agents. And next is the agents which blocks the activation of adrenergic receptors. They are called as the sympatholytics. They are called as the sympatholytics. You can see here they are called as the sympatholytics. So if they are activating, they are called as mimetic drugs. If they are blocking the receptor mediated action, they are called as sympatholytic drugs, or they are the adrenergic blockers. Next, coming to the adrenergic neurotransmission. So there are 5 steps you need to remember. First step is the amino acid tyrosine. Amino acid tyrosine enters the neuron by sodium dependent tyrosine transporter. So with the help of the sodium dependent tyrosine transporter, the tyrosine gets into the presynaptic nerve terminals in the sympathetic nervous system, and this tyrosine in the neuron undergo hydroxylation by an enzyme called as tyrosine hydroxylase to form a levodopa, and then levodopa gets converted into the dopamine with the help of an enzyme called as dopa decarboxylase. So this is the first step where tyrosine enters into the presynaptic nerve terminal with the help of the channel, that is sodium dependent transporter, and then it get hydroxylated with the help of tyrosine hydroxylase to form a levodopa, and levodopa get converted into the dopamine with the help of dopa decarboxylate. And next, in second step, what happens is the dopamine is transported into the synaptic vesicle and they gets converted into the norepinephrine with the help of dopamine beta hydroxylase. So in the synaptic vesicles, you have only the norepinephrine predominantly. So dopamine, after entering into the vesicle, they gets converted into the dopamine norepinephrine with the help of an enzyme called as dopamine beta hydroxylase. In the third step, what happens is whenever the action potential arrives, there will be triggering of the calcium channel. So what will happen? The action potential triggers the opening up of the calcium channels, leading to the calcium influx. That means the calcium enters into the presynaptic nerve terminal. There will be increase in the calcium in the neurons, which are responsible for fusion of the synaptic vesicle with the presynaptic membrane. Thereby the vesicle can release the contents which are there in the vesicle. So what is the content which is there in the vesicle that will be released into the synapse? That will be your norepinephrine. So the fourth step is norepinephrine will bind to the postsynaptic receptor which are present on the effector organs, and they trigger some intracellular responses. And also some of the norepinephrine can bind to the presynaptic receptor, resulting in decrease in the norepinephrine receptor. So in the presynaptic receptor means the norepinephrine will bind to the alpha 2 receptors, leading to the inhibition of the release of the norepinephrine into the synaptic cleft because of their negative feedback mechanism. So what will be your fifth step? Fifth step is the norepinephrine will diffuse into the circulation and they get inactivated with the help of enzyme called as catechol O methyl transferase to form an acetate and the choline, and this choline will be taken up into the synthesis of the adrenaline or the norepinephrine again, and most of the norepinephrine will be transported back into the neuron by sodium chloride dependent norepinephrine transporter which is present on the presynaptic nerve terminals. With the help of these transport, the norepinephrine will be getting back, there will be reuptake of the norepinephrine into the presynaptic nerve terminals, where again the uptaken norepinephrine will enter into the vesicle and it will be stored for future use, and it can be recycled or it can be broken down by the enzyme called as monoamino oxidase to form an inactive metabolite inside the presynaptic nerve terminal itself. So these are the 5 steps you need to remember under the adrenergic neurotransmission. So next, coming to the some of the very important point to remember, that is uh, preganglionic sympathetic neurons. Preganglionic sympathetic neurons also releases acetylcholine as a neurotransmitter. So all the preganglionic, whether it is parasympathetic or sympathetic, all these preganglionic neurons will release one type of neurotransmitter, that is acetylcholine. So acetylcholine will going to act on the nicotinic receptors which are present on the ganglion, and then the ganglion gets stimulated and the nerve impulses will pass through the postganglionic sympathetic neuron, postganglionic sympathetic neuron to release the norepinephrine. In case of parasympathetic nervous system, there will also be a release of the acetylcholine instead of the norepinephrine. Since it is a sympathetic nervous system, so after the activation of the nicotinic receptor in the ganglion by the acetylcholine, the postganglionic sympathetic neuron will release norepinephrine. And also remember, the nicotinic receptors are also present on the adrenal medulla, which are present in the top surface of the kidney. So nicotinic receptor activation in the adrenal medulla will going to release 20% of the norepinephrine and 80% of the epinephrine. So predominantly adrenal medulla will going to release 80% of the epinephrine into the circulation. So once epinephrine and norepinephrine are released into the circulation, so these catecholamines or the neurotransmitter, they binds to the receptor on the effector organs with the help of the alpha and the beta receptors. So their actions are mediated by the receptor, that is the adrenergic receptor, namely the alpha and beta receptor. So coming to the adrenoreceptors. So adrenoreceptors, we have alpha 1 receptors, alpha 1, we have alpha 1, alpha 2, beta 1, beta 2 and the beta 3. So let us understand where these receptors are located and what are their functions. So alpha 1 is located in most of the vascular smooth muscles. They are located in the pupillar, dilator pupillar, that is on the radial muscle fibers of the iris. They are present in the pilomotor smooth muscles. They are present on the bladder trigone as well as the prostate smooth muscles. They are present in the hepatic system in the liver, and since it has got vascular smooth muscle alpha 1 in the vascular smooth muscles, they are going to cause contraction, leading to the increase in the vascular resistance, increase in the peripheral vascular resistance. So activation of alpha 1 on the pupillary or radial muscles of the iris will going to cause contraction, leading to the mydriasis, that is mydriasis means dilation of the pupil. And pilomotor smooth muscles will also lead to contraction of the smooth muscles in the pilomotor, leading to erection of the hair. And bladder trigone contraction will occur, again the smooth muscles in the prostate will going to cause the contraction, leading to the retention of the urine, which may be very difficult in case of the benign prostatic hyperplasia individuals. In such case, you need to go for a alpha inhibitor in case of the BPH patient, so that it can relax the bladder trigone, as well as it will decrease the contraction of the prostatic smooth muscles, leading to a smooth flow of the urine, and the difficulty in pain and passage of the urine will be reduced in case of the BPH, especially seen in the elderly male patients. And on the liver, the activation of alpha 1 receptor lead to stimulation of the, it stimulates glycogenolysis, leading to increase in the glucose levels. So coming to the alpha receptors, so alpha 2 receptors, they are predominantly found in the adrenergic and cholinergic nerve terminals. They are found on the platelets. They are seen on the vascular smooth muscles, certain vascular smooth muscles, and also in the adipocytes. And also alpha 2 are present in the beta cells of the pancreas, beta cells of the pancreas. So activation of the adrenergic or cholinergic nerve terminals. Predominantly alpha 2 is present in the presynaptic junction, activation of which will lead to inhibition in the transmitter release. So they have got negative feedback mechanism. So if you activate the alpha 2 receptors, it creates a negative feedback mechanism, leading to a decrease in the neurotransmitter release. And platelets, it stimulates the platelet aggregation. It will produce contraction of the smooth muscles in the vascular smooth muscles. It will going to inhibit the lipolytic activity. And in the pancreatic beta cells, remember, it inhibits the insulin release. Alpha 2 activation will going to inhibits the insulin release. And what about the beta 1? Moving on to the beta 1 receptor locations, beta 1 receptors are present in the heart, they are present in the juxtaglomerular cells of the renal system or the kidney, and activation of the beta 1 in the myocardial cells lead to stimulation of the myocardial fibers, leading to the contraction of the myocardium, leading to increase in the heart rate, increase in the force of contraction, increase in the conduction capacity. Activation of beta 1 in the juxtaglomerular cells will stimulate the release of the renin, and this part will be dealt in another session. So again, renin, with the help of renin, there will be conversion of angiotensin 1 to angiotensin 2, and they are going to regulate the blood pressure. Next, coming to the beta 2. Beta 2 is located in the airways. They are located in the uterine smooth muscles and vascular smooth muscles, and they are present in the liver as well as in the pancreatic beta cells. And they are also present in the volunteer muscles, that is in the somatic motor neuron terminals. And also they are present in the heart. So activation of beta 2 receptors will lead to relaxation of the smooth muscles in the airways, leading to the bronchodilation. In the uterus, there will be relaxation of the uterine smooth muscles, there will be relaxation of the vascular smooth muscles, leading to dilation of the vascular system. And in the liver, it will going to stimulate the glycogenolysis, and pancreas, it stimulate the insulin release, whereas alpha 2 activation will lead to inhibition in the insulin release, whereas beta 2 activation in the pancreatic beta cells will lead to increase in the insulin release, and they causes tremor because of the action on the somatic motor neuron terminals. And also on the heart, it going to stimulate the rate and force of cardiac contraction. Next, coming to the beta 3. So beta 3 is present in the adipocytes. They are present in the adipocytes, which are responsible for stimulation in the lipolytic activity. They stimulate the lipolytic activity, whereas alpha 2 will going to inhibit the lipolytic activity, whereas beta 3 activation, which are predominantly found in the adipose tissue, will going to cause stimulation of the lipolytic activity. So D1 is mainly located in the renal blood vessels and splanchnic blood vessels. Activation of D1 receptors will lead to vasodilation, and there will be decrease in the vascular resistance. And next we have a D2 receptor, which is mainly located in the nerve terminals, and these activation will inhibit the adenyl cyclase activity. So coming to the catecholamines. So under catecholamines, you have three important catecholamines, that is epinephrine, norepinephrine and the dopamine. And epinephrine has got activity on the all these are the adrenergic receptor agonists. Epinephrine activates all the alpha as well as beta receptors. It will going to activate alpha 1, alpha 2 and beta 1 as well as beta 2 and beta 3, whereas norepinephrine has got predominant action on the alpha receptors, especially on the alpha 1 receptors, and they act on including alpha 1, they also act on alpha 2, beta 1 and beta 3, and it does not have any beta 2 activity. So please remember, norepinephrine is devoid of beta 2 action. And next we have a dopamine, and dopamine has got a dose dependent action which you need to remember. So at low doses they are going to activate D1 receptors, at intermediate or the moderate doses they are going to activate, in addition to D1 receptor they are going to activate the beta 1 receptors in the heart, and at the larger doses or the high doses, apart from activating the D1 and beta 1 receptor, it also activates the alpha 1 receptors. So this you need to keep in mind. So sympathomimetic agonists can be classified into directly acting sympathomimetic agent, indirectly acting sympathomimetic agent, and also we have mixed acting drugs. So directly acting drugs can be classified again into, what do you understand by directly acting, indirectly acting? So directly acting means these are the drugs which will going to directly bind to the alpha or the beta receptor to produce the activity. So what do you understand by indirectly acting drugs? Indirectly acting sympathomimetic drugs means these are the drugs which will not directly go and bind to the alpha or the beta receptor. Instead of it, they are going to act indirectly by increasing the levels of the norepinephrine. How they are going to increase? By blocking the norepinephrine transport channel or by increasing the release of the norepinephrine into the synaptic cleft. So coming to the directly acting drugs, so directly acting drugs can be classified into alpha agonist and the beta agonist, and alpha agonists are further classified into non-selective, alpha 1 selective and alpha 2 selective agonist. So non-selective example is norepinephrine, alpha 1 selective agonist is phenylephrine, alpha 2 selective agonist is clonidine, and next we have a beta agonist. So beta agonist can be classified again into non-selective, beta 1 selective and the beta 1 selective, beta 1 selective, and we have beta 2 selective, beta 2 selective. So non-selective example will be your isoproterenol, beta 1 selective agonist will be your dobutamine, and beta 2 selective agonist will be your salbutamol. This will be a shorter acting drug, and longer acting example will be your salmeterol. Under indirectly acting drugs, you have drugs which are able to increase the release of the norepinephrine. Those are the examples, that is the amphetamine and tyramine, and there are also drugs which can inhibit the reuptake of the norepinephrine back into the presynaptic terminals. So this will be done by cocaine and antidepressants. So this is the classification of sympathomimetic agonists. So let us understand each one of them based on their pharmacological actions. So before going to that, let us understand the pharmacokinetic property. Catecholamines are rapidly metabolized by enzyme called as, what is the enzyme which is responsible for the metabolism of the catecholamines? Those are the catechol O-methyl transferase and monoamino oxidase. So adrenoreceptor agonists are relatively inactive by oral route and must be given parenterally. And amphetamine, exception to this will be your amphetamine, which are resistant to monoamino oxidase activity as well as COMT enzyme, and why means they do not belong to the catecholamine groups. So amphetamine does not have catechol group, because of which they are resistant to monoamino oxidase as well as catechol O methyl transferase activity. So tyramine, whenever tyramine gets metabolized, they get rapidly metabolized by the monoamino oxidases. So tyramine is an indirectly acting sympathomimetic drugs, so they gets rapidly metabolized by monoamino oxidases and is inactive orally. So exception is whenever the patient is taking monoamino oxidase inhibitor, the tyramine activity will be more, it will be prolonged because of the monoamino oxidase enzyme will not be there for to metabolize the tyramine. And as you know that monoamino oxidase inhibitor, where do we use? We use it in case of treatment of depression. Next, coming to the patient, whenever they are taking monoamino oxidase inhibitor, whenever the patient who is on monoamino oxidase inhibitor consumes tyramine containing foods, tyramine containing fermented food, what will happen is the tyramine concentration will increase and it will not be metabolized since MOHO is not there because MOHO is already inhibited. So tyramine concentration will rise, which will lead to increase in the release of the norepinephrine, leading to increased hypertensive crisis or hypertensive reaction. So you should be very careful. So such kind of the hypertensive crisis can be treated with the help of phentolamine. So next, coming to the mechanism of action. Mechanism of action, a very important thing you need to remember. So coming to the mechanism of action, uh, let us understand the adrenergic agonist actions based on their alpha receptor activity and beta receptor activity. So alpha receptor effects are mediated through G protein coupled receptor, a particular subtype of G protein coupled receptor, that is GQ mediated alpha 1 mediated responses. So they are going to activate the phospholipase C enzyme, leading to conversion of the inositol phosphate into the inositol triphosphate and diazyl glycerol, and these secondary mediators will going to increase the release of calcium from the sarcoplasmic reticulum, and the calcium concentration will increase, leading to smooth muscle contraction. So alpha 2 receptor activation is mediated. Activation will lead to stimulation of G protein coupled receptor. The subtype will be GI type, inhibitory type. They inhibits the adenyl cyclase activity, leading to decrease in the cyclic AMP levels. And next, apart from that, alpha 2 receptor activation will also lead to opening up of the cardiac potassium channels, leading to decrease in the heart rate, that is it leads to bradycardia. So beta receptor effects are mainly mediated by GS type of G protein coupled receptor, where activation of GS type will lead to increase in the cyclic AMP levels, which in turn leads to increase in the protein kinase A activity. So this protein kinase A activity in case of beta 1 receptor activation lead to increase in the calcium levels. This increased calcium levels will lead to cardiac contraction. So cardiac contraction will be there. So cardiac contraction. And next, the beta 2 receptor activation will lead to increase in the calcium sequestration in the sarcoplasmic reticulum, thereby calcium concentration reduces, leading to relaxation of the smooth muscles, relaxation of the vascular smooth muscle, leading to the vasodilation. So beta 1 in the heart, it has got contractile ability, whereas beta 2 activation in the smooth muscles has got relaxation activity. And coming to the individual flow chart, how this drug will going to produce its mechanism of actions. So alpha 1 activation, whether it be alpha 1 M1 M3 muscarinic 1 or muscarinic 3 or histamine 1 or etc, or vasopressin 1, will lead to activation of GQ coupled receptor, leading to increase in the phospholipase, leading to conversion into the inositol or triphosphate and diazyl glycerol. Inositol triphosphate lead to increase intracellular IP3 receptor activation, leading to calcium release from the sarcoplasmic reticulum, and this will lead to increased cardiac contraction. On the other hand, diazyl glycerol will going to activate protein kinase C and then brings about the enzymatic activity and the intracellular response. And next we have a M2 or the alpha 2 or D2 receptor mediated action through GI coupled receptor, where they are going to inhibit the adenyl cyclase activity and decrease the cyclic AMP, and this is responsible for the contraction, this is responsible for vasoconstriction, and also there will be opening up of the cardiac potassium channel, leading to decrease in the cardiac contractility as well as heart rate. Next we have a beta 1, beta 2, beta 3 or dopamine 1, histamine 2, H2 and V2 receptor mediated activity through GS coupled receptor, which activate adenyl cyclase, leading to increase in cyclic AMP levels, which in turn will going to activate the protein kinase A, in turn will lead to increase in the calcium levels in the myocardium, leading to the myocardial contraction, leading to increase in the heart rate. On the other hand, there will be phosphorylation and faster sequestration of the calcium into the sarcoplasmic reticulum, which lead to relaxation of the vascular smooth muscles. That means it will cause vasodilation. So please remember, beta 1 is predominantly located in the heart and beta 2 is predominantly located in the vascular smooth muscles. They have got entirely different activity. So beta 1 will cause cardiac contractility, beta 2 will cause vascular smooth muscle relaxation and vasodilation. So coming to the pharmacological actions of individual system. On the central nervous system, you need to remember that catecholamines do not enter the CNS readily, and the sympathomimetic agents like amphetamine, cocaine can enter the CNS, and they have got stimulatory effect. So what are the stimulatory effect that amphetamine and cocaine cause? And they cause mild alerting effect, they reduce the fatigue, and they can progress to anorexia, euphoric movements and insomnia. And what will happen to the repeated dose of amphetamine? So the repeated dose of amphetamine will lead to rapid development of the tolerance and the dependence, and this will be very dangerous. So in case of very high doses of the amphetamine, so there will be marked anxiety, aggressiveness and paranoia, and less commonly seizure. So which side effects will going to differentiate from amphetamine and the cocaine means the overdose of cocaine is responsible for causing seizures. The seizures are very commonly seen in case of overdose of cocaine. So next, coming to the action on the eye. So what will be the action on the eye? So as we discussed earlier, the location of the alpha 1 in the eye is present in the radial muscle fibers of the iris. So we have some topical agents like phenylephrine and other alpha agonists, which will going to activate the dilator pupil or the smooth muscles of the pupillary dilator, which is present in the iris, leading to the contraction, leading to the dilatation of the pupil. The process of dilatation is called as mydriasis, and the drugs which are causing mydriasis is called as mydriatic drugs. And here the advantage is the accommodation is not significantly affected because accommodation is controlled by the M3 receptor, which is present in the ciliary bodies, which are not blocked by the alpha receptor agonist. And we have a non-selective alpha agonist, and these non-selective will going to increase the outflow of the aqueous humor through the uveoscleral drainage system, that is epinephrine, and this will going to decrease the intraocular pressure. On the other hand, we have a alpha 2 selective agonist, which will going to decrease the synthesis of the aqueous humor, thereby again it will going to decrease the intraocular pressure, which are helpful in the treatment of glaucoma. Moving on to the bronchi, so the example is the isoproterenol and the albuterol, which is the other name for salbutamol. So beta 2 activation will lead to relaxation of the smooth muscles in the bronchi, leading to the bronchodilation. So beta 2 agonists are most efficacious drug in relieving the acute bronchospasm. And moving on to the gastrointestinal tract, the gastrointestinal tract activation of either beta 1 beta or the alpha receptors lead to contraction, lead to relaxation of the smooth muscles, relaxation of the smooth muscles here. So moving on to the genitourinary tract, so activation of the alpha receptor which are present predominantly on the bladder trigone and the sphincter area, as well as prostate smooth muscles, will lead to contraction and the increase difficulty in the passage of urine will be experienced in individuals who are having benign prostatic hyperplasia. So alpha blocker would be preferable in such condition, so that they can clear the blockage created by the alpha mediated actions around the bladder trigone and the sphincter area, as well as on the prostate smooth muscles. So coming to the vascular system, in the vascular system, let us see what happens with respect to the activation of individual receptors. So we have alpha 1 agonist, alpha 2 agonist, beta agonist, and dopamine. So alpha 1 agonist, the example is phenylephrine. So phenylephrine activates the alpha 1 receptor, leading to contraction of the vascular smooth muscles, especially in the skin and splanchnic blood vessels, leading to increase in the peripheral vascular resistance and the venous pressure, leading to increase in the blood pressure. So see, these drugs should not be given in case of hypertensive individuals. So apart from that, increase in the BP will lead to compensatory reflex bradycardia. So by the vagal activity. So coming to the alpha agonist, the example is clonidine. Clonidine is a centrally acting alpha 2 agonist which can be given by intravenously or topically through nasal spray. It leads to vasoconstriction and they decrease the congestion. Whereas when it is given orally, it has got unique mechanism that it accumulates in the CNS and it decreases the sympathetic outflow. How means activation of these alpha 2 is located in the presynaptic nerve terminals. Activation of alpha 2 in the presynaptic nerve terminals will lead to negative feedback mechanism. That means it will going to inhibit the release of norepinephrine, thereby it decreases sympathetic outflow and they decreases the blood pressure. And so that's why clonidine should not be withdrawn abruptly, because it can cause the sudden hypertension. Rebound hypertension can be seen if clonidine is withdrawn suddenly. Coming to the beta agonist, beta 1 agonist, the dobutamine will going to activate beta 1 agonist, which are responsible for cardiac contraction. They are the potent cardiac stimulants and they have got less effect on the vessels. Whereas beta 2 agonist, example is salbutamol. Again, salbutamol acts mainly particularly on the beta 2 receptor located in the bronchial smooth muscle, leading to the bronchodilation. Again, beta 2 receptors are present in the vascular blood vessels, leading to smooth vascular smooth muscle relaxation, leading to dilation of the blood vessels. And there will be decrease in the arterial tone in the skeletal muscular muscle vascular bed, and decrease the peripheral vascular resistance, as well as there will be decrease in the arterial blood pressure. What happens when the dopamine 1 agonist is activated? So dopamine 1 agonist is activated, it will lead to vasodilation because D1 is present in the renal as well as the splanchnic blood vessels, leading to relaxation of the vascular smooth muscles, leading to vasodilation. So these are very useful. Why means whenever there is a failure, whenever there is a shock which are associated with renal failure, the renal function will be shut down and renal perfusion will be reduced. In such cases, giving dopamine will going to activate the D1 receptors in the renal vascular system, and it will going to increase the perfusion to the renal system. Thereby it prevents the renal damage and renal failure in case of the patient who are having shock. Next, coming to the effect on the heart. So effect on the heart is, you should understand one thing about the heart with respect to the autonomic nervous system. What is that? So whenever any catecholamine acts on the heart, it predominantly activates the beta 1 receptors. So what is the three functions of beta 1 receptor activation in the heart? So there will be increased rate of cardiac pacemaker activity, there will be increased AV nodal conduction activity, AV nodal conduction velocity, there will be increased cardiac force of contraction. So there will be increase in the heart rate, increasing the AV nodal conduction, increase in the contractility. So there will be positive inotropic effect, there will be positive chronotropic effect, there will be positive dromotropic effect with respect to activation of the beta 1 in the heart. Next we have a what is the net cardiovascular actions. So norepinephrine will going to act activate both alpha 1 as well as beta 1 receptor, leading to increase in the blood pressure, which in turn lead to reflex increase in the vagal outflow. So the reflex vagal effect may dominate any of these directly beta activated effects on the heart, and the slow infusion of norepinephrine will initially lead to increase in the blood pressure followed by bradycardia due to the vagal activity, reflex vagal activity. So if the reflexes are blocked with the help of the ganglionic blocker or the antimuscarinic drugs, what happens is the norepinephrine will have direct activity on the beta 1, leading to tachycardia. So it is called as direct beta 1 mediated tachycardia. So if the reflex is blocked, what happens if you give a pure alpha agonist like phenylephrine? There will be routine slowing of the heart rate on the by the baroreceptor reflex. On the other hand, if you administer a pure beta agonist like isoproterenol, since you will be blocking the vagal activity, so what happens is almost always the beta agonist will going to increase the tachycardia risk. That is, there will be increase in the heart rate whenever you give a pure beta agonist in conditions where you would have already blocked the ganglionic blocker and the antimuscarinic with the help of ganglionic blocker and the antimuscarinic drugs. So next, coming to the sympathomimetic effects on the vascular resistant blood pressure and the heart rate. So this is a chart which will going to describe you about the effects of the drugs on the vascular system. The phenylephrine will going to increase the vascular resistant, skeletal muscle vascular resistant, renal vascular resistant, and mean BP will increase. Because of the reflex response, there will be decrease in the heart rate. On the other hand, isoproterenol, which mainly acts on the beta 1 receptors, and what will happen is they has got beta 1 as well as beta 2 activity because of their non-selective activity. So there will be decrease in the vascular resistance, there will be decrease in the mean blood pressure because of activity on beta 2 response. So since it has got activity on beta 1 also, it will going to increase the heart rate. What happens with respect to norepinephrine? Norepinephrine will going to increase the both skeletal as well as skin splenic vascular resistance. There will be increase in the renal vascular resistance, the mean blood pressure will going to shoot up, and initially there will be reduction in the heart rate due to the compensatory reflex responses, but afterwards if the reflex is blocked with the help of the ganglionic blocker or antimuscarinic agent, so there will be direct stimulation of beta 1 leading to tachycardia. Next, moving on to the uh, some of the important thing to remember, that is diastolic blood pressure is mainly affected by peripheral vascular resistance and the heart rate. Adrenoreceptor are the having greatest effect on the vascular resistance because of their alpha and beta 2 receptor mediated activity, and pulse pressure, which is a systolic minus diastolic pressure, is mainly determined with the help of stroke volume, which is a function of the force of cardiac contraction, and which in turn influenced by the beta 1 receptor activation. And systolic pressure is a combination of diastolic plus pulse pressure, which again a function of both alpha mediated and beta mediated effects. Coming to the metabolic and hormonal effects, so here you should remember that a very important to remember is what happens whenever there is a sympathomimetic drug act on the metabolic system. So beta 1 agonist will going to increase renin release by acting on the juxtaglomerular cells in the kidney. Beta 2 agonist will going to increase insulin secretion, and all beta agonist will going to activate lipolytic activity through beta 3 receptors. And in this with at this stage, let us understand if epinephrine is given, what happens to the insulin secretion? So epinephrine on activation of alpha 2 receptor, it will going to inhibit the insulin secretion. On activation of beta 2 receptor, it enhances the insulin secretion, and the predominant effect of epinephrine on insulin will be inhibition of the insulin secretion. Whereas beta 2 agonist activity is mainly it increases insulin secretion. So coming to the beta 2 agonist will increase glycogenolytic activity in the liver, which lead to hyperglycemia, and this will be counter reacted or countered by the increased insulin levels. And whenever there is a transport of glucose out of the liver, this will be associated with initial hypokalemia, because potassium will also be going into the cells from the plasma or the blood. And also whenever there is a transport of glucose into the peripheral organs, especially the skeletal muscles, again the potassium will going to accompany the glucose and leading to decreased potassium in the blood levels, leading to hypokalemia. So one of the side effect with respect to the beta 2 agonist usage will be your hypokalemia, which can further lead to tremors. So coming to the beta 2 selective agonist, when they are given parenterally, it can increase the glucose levels, it can increase the lactate levels, it can increase the free fatty acid in the plasma, as well as hypokalemia. And hypokalemia, why you should be very careful means, hypokalemia will lead to disastrous arrhythmia if a patient is having a cardiac disease or is taking a digoxin or a diuretic. So hypokalemia can increase the risk of digoxin toxicity and further leading to arrhythmia and the death. And diabetes patient, you should remember that whenever they take beta 2 agonist, which can lead to hyperglycemia, the diabetic condition may worsen and higher doses of insulin may be required in such individuals. So coming to the how blood pressure is controlled in case of pheochromocytoma. So control mechanism, blood pressure control mechanism in pheochromocytoma. If a patient with pheochromocytoma comes, you need to remember it is a adrenal tumor. It is an adrenal tumor which can remain for several months or even years before symptoms and signs lead to diagnosis. And the probable compensatory responses to chronic increase in the blood pressure, which is mainly caused by tumor, adrenaline tumor, releasing large amount of norepinephrine. Because of the release of large amount of catecholamine from the adrenal tumors, it will increase the blood pressure, will lead to hypertensive crisis, and you should be very careful. And compensatorily, there will be reduction in the renin levels, angiotensin and aldosterone levels. So reduced aldosterone levels, what will happen? More salt and water uh, will be excreted by the kidney, that will lead to reduction in the blood volume, and its mass will not be affected, but hematocrit often is increased because of reduction in the blood volume. So pheochromocytoma, which is an adrenal tumor, it's a tumor which releases only norepinephrine, will have a compensatory bradycardia, and in most of the patient they release enough amount of epinephrine that will lead to maintain the heart rate at normal, or even they increase the heart rate. So coming to the clinical uses of this adrenergic receptor agonist. So this can be used in case of anaphylactic reaction or the anaphylaxis. So it is a type 1 hypersensitivity reaction. Here the drug of choice will remain a epinephrine. So adrenaline, A for A anaphylaxis, adrenaline will be your drug of choice, and it should be immediately treated because it's an emergency condition, because it will be associated with hypotension, bronchospasm and angioedema. So epinephrine, by activating the alpha 1 receptor, they are going to overcome the hypotension because of the vasoconstriction, and they increase the blood pressure. Whereas epinephrine activates the beta 2 receptors in the bronchial smooth muscles, leading to the bronchodilation, which overcomes the bronchospasm and also the angioedema. Since epinephrine is a adrenaline is a physiological antagonist of histamine, they are going to decrease all the inflammatory mediators, all the inflammatory reactions mediated by the H1 receptors. So angioedema will be reduced. So along with that, you should also need to administer antihistaminics and corticosteroids for the faster relief. So please remember, so epinephrine is effective physiological antagonist of anaphylaxis mediators. Coming to the central nervous system, so drugs like amphetamine, methyl phenidate can be used in the treatment of narcolepsy and weight reduction because of their anorexient effect. So we'll use amphetamine for both narcolepsy and weight reduction, and also it can be used in addition to this in case of attention deficit hyperactivity disorder. We'll use methyl phenidate, and cocaine is not used because of their abuse potential. And why abuse? Because it elevates the mood and it creates the euphoric movements and high addiction liability. So all this amphetamine, methyl phenidate, cocaine has got the addiction liability, and these drugs are less used because of their abuse and misuse for deferring the sleep, for mood elevation and the euphoria. So coming to the uses of high, uh, the adrenergic agonist can be used for treating any irritation or the allergy leading to the conjunctival itching, congestion caused by the irritation or the allergy. Here you are going to use a decongestant, that is phenylephrine, and also you can use tetrahydrozoline. And apart from that, phenylephrine is used as a mydriatic agent. The advantage is they do not cause cycloplegia, and the newer alpha 2 agonist can be used in the treatment of glaucoma like apraclonidine and brimonidine. So apraclonidine and brimonidine, they reduces the synthesis of the aqueous humor, thereby it reduces the intraocular pressure. So on the bronchi, salbutamol is a drug of choice for acute bronchospasm. So they are useful in case of treating acute asthmatic bronchoconstriction. So in such conditions, you need to give a beta 2 selective agonist will be the drug of choice. So short acting beta 2 agonist like salbutamol, metaproterenol and terbutaline will be a drug which are preferred in case of treating acute bronchospasm. It will be life saving drug, but they are not preferred for prophylactic activity. And coming to the longer acting beta 2 selective agonists like salmeterol, formoterol, we have olodaterol, velanaterol, etc. And these drugs, you should remember, is they are the agent for prophylaxis in case of asthma and COPD, and the combination is used whenever the long term history of bronchial asthma and COPD is present. Along with long acting beta 2 selective agonists, you need to go with corticosteroids and antimuscarinic drugs like ipratropium bromide, which can be used in the form of inhalation. Next, coming to the cardiovascular application, and these drugs, epinephrine, norepinephrine, and the dopamine can be made utilized in the treatment of septic and the cardiogenic shock. Septic and the cardiogenic shock, and here you can use norepinephrine because of the predominant activity on the alpha 1 receptor. Dobutamine and dopamine can be preferred in case of cardiogenic shock, and their usage should be very careful because they are arrhythmogenic in nature. So whenever this vasoconstriction is needed, you can go with the alpha 1 agonist, and in case of cardiac arrest, you can go for intravenous injection or intracardiac injection of the adrenaline. So epinephrine intravenously, or you can give direct intracardiac injections. So you can use the isoproterenol, which activates beta 1 receptor in case of AV block, and epinephrine can be used in some other conditions like for local hemostatic activity to prevent the local bleeding like epistaxis, and phenylephrine can be used as a nasal decongestant, and norepinephrine and phenylephrine can be used in treatment of shock, and they can be mixed with local anesthetic agent to increase the duration of local anesthetic agent as well as to decrease the systemic toxicity, so that you can use the lesser dosage of the local anesthetics. So to reduce the loss of anesthetic from the area of injection into the circulation. And also it is epinephrine are useful in treating the chronic orthostatic or postural hypotension. Apart from that, you can also give oral ephedrine or a newer orally active alpha 1 agonist, that is the midodrine, for the treatment of chronic orthostatic hypotension. So coming to the genitourinary tract uses, so drugs can be used to suppress the premature labor. So as you know that uterus is having a smooth muscle, that is the detrusor smooth muscles, which contains which receptor, beta 2 receptor. Activation of that beta 2 receptor will going to relax the urinary, that will going to relax the uterine smooth muscles, thereby it will going to relax it. So it will going to prevent or suppress the premature delivery or premature labor, which gives a time for the lung maturation in case of prematurity. So we have a ritodrine terbutaline as a beta 2 agonist. Apart from that, to suppress the premature labor contraction, you can use non-steroidal anti-inflammatory drugs, calcium channel blockers, and magnesium sulfate. And also it can be used to improve the urinary continence in elderly and children's with anuresis. So especially you can use a long acting oral sympathomimetic, that is ephedrine, and their actions are mediated by alpha receptors. So remember, do not confuse with BPH. Only in case of elderly females who are having any urinary incontinence, you can improve the tone of the trigone of the bladder as well as the sphincter by giving the alpha 1 agonist. So alpha is located in the trigone of the bladder and the prostate, and this will going to help in terms of improving the urinary incontinence in elderly and anuresis in case of the children's. So coming to the drug toxicity which are associated with the adrenergic group of drugs. So it can cause excessive vasoconstriction leading to the increase in the blood pressure. It can cause cardiac arrhythmias. It can precipitate myocardial infarction. It can cause hemorrhagic stroke. It can lead to pulmonary edema and hemorrhagic risk. And alpha 1 agonist can cause hypertension. We should be very careful in case of patient who are having hypertension. And beta 1 agonist can cause sinus tachycardia and arrhythmias as well, and beta 2 are more prone for skeletal muscle tremors. So important note you need to remember is none of this drug is perfectly selective, and at high doses beta 1 selective agents may have beta 2 action and vice versa. There is no uh, 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 that demarcation that it is only selective only at specific doses. Whenever the dose becomes higher, the selectivity will be lost. And coming to the cocaine is a special importance of drug abuse, and they can cause cardiac arrhythmia, infarction, and very important side effects that will going to differentiate from the amphetamine seizures. So as recapitulating or to coming to the end of the session, let us summarize the adrenergic group of drugs. So sympathomimetic are the drugs which are the one which acts similar to that of adrenaline or the sympathetic stimulation. We have directly acting sympathomimetic agent, indirectly acting sympathomimetic agent, and mixed sympathomimetic agent. Under this, we have a adrenaline, noradrenaline, isoprenaline, and phenylephrine, and methoxamine, xylometazoline, salbutamol, etc. under directly acting sympathomimetic agent. Under indirectly acting sympathomimetic agent, we have tyramine, amphetamine, etc. Under mixed sympathomimetic agent, we have got the ephedrine and pseudoephedrine as well as mephenteramine. So this is the again revision of the adrenergic drug users. Adrenaline is useful systemically in the treatment of anaphylaxis. It is a drug of choice in the treatment of anaphylaxis or anaphylactic shock. Locally, it can be used along with lignocaine to increase the activity of the lignocaine and to decrease the dose as well as to decrease the side effects of the lignocaine, where it produces the local vasoconstriction, preventing the drug to reach into the systemic circulation. So isoprenaline, which predominantly act on beta receptors, they maintain the idioventricular rate till the pacemaker is implanted, and they are also useful in case of bronchial asthma. And noradrenaline, they should be administered very slowly. Extravasation can cause tissue necrosis, and please do not mix with the sodium bicarbonate. So as a pressure agent, it can be preferred because of their strong vasoconstrictor activity. So adverse effects and contraindications, as we discussed earlier, the contraindication should remember is in hypertensive patient, hyperthyroid, angina patient, they should not be used. Adrenal should not be given in case of during anesthesia with halothane because of the risk of arrhythmia, and with beta blocker because marked rise in the BP can occur due to unopposed alpha action. So again, the user's pressure, they can be used in shock, bronchodilators in bronchial asthma, CNS stimulants in narcolepsy, uterine relaxant in preterm labor prevention, cardiac stimulant in cardiac arrest, nasal decongestant in common cold, and anorectics in the treatment of obesity. And these are the drugs which are useful for treatment of this individual conditions. And summary, vascular uses, it can be used. Adrenergic drugs are used in vascular uses, cardiac uses. They are used in bronchial asthma, in anaphylaxis, ocular use to decongest the conjunctiva, in glaucoma, central use in ADHD, narcolepsy as a uterine relaxant, and last resort in case of insulin hypoglycemia. If no other drugs are available like glucagon and the glucose, you can go with the adrenaline, which can increase the blood glucose levels. Thank you. Hope this will going to have a important overview of the adrenergic drugs. If you find this video useful, please do subscribe to my channel I Love Pharmacology for more updates on pharmacology. Thank you.